welcome to Samsung Medical Center again. So we have a CTO case, specifically CTO bifurcation. I'm quite excited to do this procedure. So my name is Hyeon-Cheol Gwon from Samsung Medical Center. The second operator is Ju Han, the same hospital, and Woo-Jin Jang from the Jungang University Hospital. The Sang-Yun Lee is my fellowship trainee, is working as a fourth operator. So Dr. Jang will present the case for today.
네. Thank you, Dr. Kwon. I'm Dr. Jang from Jungang University Hospital. Let me introduce our case. This patient is a 60-year-old male. He suffered from exertional chest discomfort for 2 years. He had a history of diabetes for 10 years, but no other risk factors and any other medical history. Next slide. We conducted a non-invasive imaging studies on transthoracic echocardiogram. We observed diastolic dysfunction grade 1 and normal LV ejection fraction, and there was no significant regional wall motion abnormality in this exam. However, on exercise stress echocardiogram, we observed a positive post-exercise regional wall motion abnormality in the LAD territory at 9 March. Next slide. This coronary angiogram was performed 1 month ago in the aleocranial and aleocranial of RCA. There was no significant stenotic lesion throughout the RCA, but we observed collateral flows from distal RCA PL to middle LAD. Next slide. In the aleocaudal view of LCA, there was no significant stenotic lesion in the LCX, but we observed in epicranial view, we observed the mid-LAD CTO lesion with collateral flow from the LCX to diagonal branch. Thank you.
Okay, previous. So, play. Yeah. So as you can see here in the epicranial view, this CTO in LAD was tapered, and the calcified plaque is out of the way. So it looks very easy, right? The problem is that we found some total occlusion in the diagonal, so-called the CTO bifurcation. So today's topic is how to approach the diagonal side branch total occlusion. Of course, the LAD is of most of the clinical significance, so there is no pressure to have a success in the diagonal, but the back diagonal artery actually big, and only one big diagonal artery. So I'll be happy to the wire it. Next. So we did a CT angiography. So left side, actually, no. Yeah. So the left side 3D reconstruction showed the calcification away from the diagonal. And the diagonal, not ostium specifically, but just after the ostium, you can see a calcification, and the lesion in the diagonal is a little bit long. And I tried to find the evidence to try to find the hint that where is the diagonal begins, ostial. I'm not sure. Just I think I need to target the small calcium in the diagonal artery, maybe very near to ostium. Next. So today's target is LACTO bifurcation, where it used the XB7 French guiding catheter. And of course, we did the IVUS guided Antegrade wiring for diagonal CTO. If failed, maybe we can try retrograde from the circumflex to diagonal, use another guiding catheter. And finally, hopefully one stent with DCB or two-stent technique. So I'd like to learn about the strategies for LAD and diagonal artery bifurcation CTO. Maybe you can use a dual lumen catheter, or you can use a supercross, or you can try the retrograde approach. from the beginning for the diagonal. So, what do you think?
Comments from the panel?
리전 좀 돌려주세요.
But for the
슬라이드
LAD,
앞에 왼쪽.
the proximal stump is tapered, so maybe you can try antegrade first.
슬라이드 디스커션 슬라이드.
전전.
라이브 엔조. 오케이, 돌아가고 있네.
And the ostium of diagonal looks as not the calcium. Just after ostium of diagonal has a calcification. So, any comment from the panel?
As Dr. Kwon presented, LAD approach looks reasonable, but I don't see the arth of diagonal branch. From the images of CT angio, it looks like diagonal arth should be next to the calcification in the proximal LAD, but I'm worried I don't see the ostium of diagonal branch.
다음 슬라이드. So the targeting the calcium is a reasonable approach, you think? So another question, last slide, please. Next. Yeah, I draw this picture myself. I hope you like it. So,
Very good.
probably the diagonal ostium is no stump at all. I think most likely next. So we did IVUS guided approach. Next. Problem is that we can, where we can try first. Next. In the two-dimensional IVUS, actually, we can see just the wire position in the cross-sectional area. So, but sometimes wiring puncture the proximal part of the diagonal, the distal part of the diagonal. Based on the pathology of the bifurcation, usually plaque is placed away from the carina. So the number 3 approach is reasonable, but it's not so easy, right? So I tried several times for that the location to end up with the subintimal position of the wire. So what do you think? I prefer to try proximally or distally, technically and pathologically. What do you think?
If you approach to number 1 position, you will make a new carina.
New carina. Okay. In that case, I should end up with a two-stand technique because plaque can be shifted to the carina.
Yes.
But the success rate may be higher.
Looks like a perfect strategy, but I think we should consider retrograde approach for the diagonal branch. Where does the collateral come from? Is
circumflex.
it from
Angiography. 앞에 슬라이드 앞으로. 슬라이드 앞으로. Okay. Epicaudal. The collaterals from circumflex. So let me show you the angio. Today's angio. Angiography on the screen. 네. Okay. 우리는 다른 거 보고 있네. Anyway, you can see epicranial. You can see the circumflex is coming from the diagonal is coming from the circumflex. Next. We did the bilateral angiography. You can see the LED total lesion is very short, about 10 millimeter, 12. Next. This area cranial, nothing much. Next. Next. So anyway, I'll show the circumflex collateral afterwards. I try the UV3 wire supported by the corsair extra small. Next. It was very, very quick. This is live, almost live. And this septal. This is LED. Okay, just 10 seconds. Next. The retrograde angiography. So this position is in the septal. Next. Next. Okay. The UV3 changed to the run-through wire, workhorse wire. Next. Yeah, ballooned it. Next. 1.5 20 millimeter balloon. Next. So this is angiography after the 1.5 balloon. Still, the diagonal proximus looks denser than before.
Yeah, I believe so.
I don't know why. There is a supply from the LED. I don't know. Next. Anyway, so my intention was the Antegrade first, but we are waiting for 30 minutes. We have plenty of time. We try to find the collateral. This is a lateral view. Yep. Can you tell which branch is supplying the diagonal? It was very, very difficult. Next. So we tried lowest circumflex, obtuse marginal. Not this one. Next. Next. The second one. No. Next. The most proximal one. Actually, this is early diagonal, so we should try first obtuse marginal first, as you recommended. Anyway, collateral. Yeah. So, do you want to try this retrograde approach, right?
It's really tricky.
Actually, yeah, tricky.
The collateral is very small.
And Dr. Gwon, it seems there are several lesions in proximal circumflex and mid area. Did you check IVUS before microcutting?
Yeah, I did IVUS.
Yeah.
I did IVUS afterwards. Oh, I can show you the ostium by the IVUS integratedly, but we are now considering the retrograde approach at this time. So I'm afraid of actually the cardiac tamponade. At this point, we can perforate the collateral here. It will be end up with the cardiac tamponade. Anyway, we tried. Next. Next. 다 조정이 안 됐어? 와이어링 한 거. 와이어링을 조정. Yeah, actually, yeah, in that position, actually, we used the SO3.
Yeah, so say.
SO3 to get there, but stopped at the time. Stopped here. We tried many times, but we can't overcome the acute bending, multiple bendings there. So you should have tried more.
I don't think so.
I didn't ask you.
Well, actually, I think you can pursue a little bit more, but I recommend that using the guiding catheter. Now you're using for the RCA. Now you don't need for any need for the LAD channel looking. So
Yeah.
you can use
right.
this as
Remove
a second guiding catheter, and then use the retrograde approach from the second guiding catheter.
Yeah, right. So if the wire is successfully crossed the diagonal to LAD, so we change to a right coronary guiding catheter into the another XP for left, and we finished work. But we tried about 5 to 10 minutes. It was not successful. So I quit. So what do you think? Now I'm asking you.
As Dr. Gwon mentioned, the collateral branch is very narrow and tortuous, and wiring is not so easy. And if the cardiac tamponade occurs, that position is very dangerous. So I think ipsilateral collateral retrograde approach is the last resort, and we can adhere to Antegrade approach using IVUS in this case.
So for collateral approaches, SO3 is the best option for Korean doctors. So is there any better wires available in Japan or other countries?
Yeah, but Dr. Kwon, for
Yep.
determining the tortuosity of the collateral channel, you may need two view, not only one lateral view. This is you
Actually,
can see the
in
very
other
shortening.
view, oh yeah, and this position shortening, right?
Yeah. So how about the areocranial with a tip injection from the corsair?
Yeah. Unfortunately, we already removed the corsair here
okay,
because
okay.
you need to use a Sasuke for the diagonal approach. So if Antegrade fails, we get back to the retrograde again. We try the different view and try more harder.
Always the shortening view looks like
Yeah.
very tortuous.
Right, yeah. Actually, lateral view is good for the initial the wiring, but we need to change the wiring. Okay, so this is IVUS image. IVUS on the screen, please. IVUS on the screen. Okay. Actually, it is very, even after the 1.5 balloon, it was very difficult to proceed the catheter. Anyway, the vessel size is 3.0. There is a very focal 2 millimeter length of a neck and ring calcification. And this is eccentric calcium around here. It should be there. Yeah, you can see diagonal in the 11 o'clock. Too quick, right? No, sorry, this one. So actually, we like to visualize the diagonal ostium by the manual pullback. Next. This was the proximal. I adjust the length, the depth of the IVUS catheter. So this is proximal portion of the total occlusion. Next, 11 o'clock. Next. This is the distal position. Looks alike. And the angiogram. Next. Angiogram on the screen. 여기 distal인가? This is the distal location of the IVUS examination. We did the angiography. Distal. Next. This is proximal. No. 그 전에. This is distal. 그 전에. Proximal. I don't know. This look different. So anyway, we like to wire targeting the small calcium in diagonal near ostium. So this is where we are. So we try. We inserted the Sasuke. wire 좀 잡고. Sasuke, and the first choice of wire was UB3.
I'm sorry, I may misunderstand your comment. So don't you make any rotation before the diagonal branch wiring? Because
Actually,
yeah.
This is eccentric calcium. So I don't think we need a rotablation here. It's a very short 1 or 2 millimeter length of a necking ring. So the IVUS study showed that the 5 millimeter more of necking ring is indication of rotablation. So I don't like to do that actually. Balloon easily break the calcium in this small amount of calcium.
Okay. I don't think the napkin ring and the source calcification is not so problem on this for procedure. So opposite side of the below the diagonal branch calcification is a much difficult problem. So after wiring, if you make the procedure to both in the branch already in the diagonal, sometimes you have a problem about in the carina shift. So you have to prevent in the carina shift. So before the diagonal wiring. So its solution is the only root ablation.
Really. Even with the rotablation, if I wired proximally, plaque shift is inevitable.
Yeah,
Yeah,
plaque
maybe
shift.
rotablation is preferred, so yeah.
Sorry, yeah.
That's one choice.
Plaque shift is not so important. Carina shift isn't so much problem.
I have many papers about that. I will review paper for the corona shift, the plaque shift. Actually, studies show that the plaque shift is the only reason of the side branch occlusion. Corona shift, you see some the filling defect, but then not always associated with the side branch occlusion. This was shown FFR study 2005 by Dr. Gu, Seoul National University. So, yeah, we disagree at this point, and we can discuss next time.
So you choose the UV3 for penetration,
Yeah.
the osteo?
Actually, I'm not sure. We need a discussion about that. Andrew? Sure. So, Dr. Han, you have something to say about the wire change.
I prefer a Guyana second.
What do you prefer for the? This is a little bit proximal position of the person, right? But I like to try here. Oh, no. Okay. No need to inject contrast. That's a little lower position of the calcium. There was some resistance here, so I'll try to rotate clockwise.
Yeah.
There was some progress.
Yeah, seems
I'm not
good.
sure this is inside of the. Anyway, I like to get Andrew here.
Seems nice.
No? Yes, and that 저 위에 다이스테닝 있는 거 저 위에 좀 떼어주세요.
베이스라인에서 저 성처럼 보일까?
베이스라인 엔주? 여기 그전? We are seeking for the angiogram. 그 LED balloon하고 그 다음에 찍은 거. LED balloon 그전? 전? Okay. Stop. Okay. 위로 올려놓고. Okay, we are almost there, but I'm not sure this is inside the plaque or we need to go down, right? About 7 o'clock. No, 5 o'clock. I should be very careful at this point. Y angle? No. I'm pulling back. No. I'm happy about the angle of the wire, actually. We should go 5 o'clock. No. Andrew? Sure. Yeah, we should go 5 o'clock at this point. Yeah, you can help me by discussion.
What about I was checking the LED?
I was check. Okay. Yeah. I was. No, we didn't use IVUS here. Actually, our first plan was IVUS in the LED in front of Sasuke. But there is a lot of the work to do. So, do you use IVUS in front of Sasuke inside of this is a 7 French guiding catheter.
What kind of IVUS do you have?
IVUS, the Boston.
The Boston Scientific.
Maybe
you know?
not easy.
Not easy, right? Opticross. Not opticross, not optimal cross. So I pull back and try again. Maybe I can push the suscipital further and remove the. No. This is not the case actually. So I think reshape the wire.
Yeah, it looks like you keep
It's a
Direction.
straighten actually. Yeah.
you're still in the vessel.
Yeah. That's why I use UV3, the tactile feedback, but at this moment I can see that clearly. No, outside. So I change the wire forming. Okay, you agree?
If you want to making the IVUS evaluation for this osteum of the diagonal branch, of course you can do it in the 7 French guiding catheter. But its name is in the slipstream technique from reported from the Toyohashi Health Center. So already, IVUS at first and IVUS on that set on that first wire. After that, also in the dual lumen catheter set on the same wire.
Right, yeah.
Yes, so you can easily to the check and IVUS checking the osteal information by IVUS. However, you using I think the bright chip guiding catheter. So only the bright chip catheter cannot accept in that technique.
Really?
Yes, because the inner lumen
bright,
is so small.
Small, yeah. Okay. So then we have no choice but to proceed like this. 조금 뽑고. Okay, test. 조금 더 distal로. More distal. Test. We can see some, yeah. Okay. Too much curve, maybe. We can find the same position. Yeah, here. Test. Okay. Here I let go down. Actually, the wire is not going down, facing down. No. I should have tried the lower position of the diagonal. Anybody can help me?
But your wire position is so good, so you may try a little bit more time.
Yeah.
But then change the wire to Gaia series.
Gaia 3.
Gaia,
Okay. Not 2.
not 2. Good
Oh,
progress.
Yeah. 14. You missed the best part.
How did you make
So
it?
I'm sorry to say that just 2 minutes after the TV videos off the line. So I was like, oh, really? Oh, 깜짝이야. Okay, the previous one. So this is the point where you left us. So we change the curve next. The problem is that the angle between the proximal and distal. So I was afraid to go further But anyway, it fails. I need to change to the CISO technique or the body wire technique. So I pushed it. Next. What do you think? As off the target.
Yes.
So I like to change to the body wire technique. I exchange the wire to remove the shasuke. As it's next. It suddenly popped in. So, oh my God, we got a perforation here. So finally, you can see some retrograde angiography show the wires inside of it. How do you explain it? Previous.
Subintimal passing?
Yeah, maybe. I'm not sure. We check at this position. It looks like outside of true lumen, right?
Yes, looks like.
So maybe we are
Wire ADL.
wire ADL.
Yeah.
Okay, wire ADL. So actually, sometimes it happens with the UV3 wire. I don't think it Gaia second root can make it like this. Anyway, just by luck. I'm not so proud of it. I'm not. Anyway, I like to. Anyway, we changed to. Let's check again. Angiography.
네.
Angiography. So this is inside of diagonal. Anyway, distally it's a true lumen. So I think we can dilate.
But in this angiogram, the wire is positioned in the true lumen all the way.
All the way.
Yeah, we just saw
right.
the tiny
Okay.
branches.
Okay.
Yeah.
I forgot that actually. Previous angio. I forgot that. Previous. No. 저거 전 here. 전. Actually, what we see is not lumen, but calcification, right? In the CT angiography, there was a calcium at this point. This is calcium, not the.
No.
알고
This
싶다고
is the
얘기할 것
contrast.
같아. Yeah, not the contrast. This was calcium. So it's true position. So maybe we can. This is live demonstration. So I like to check the LED IVUS first for the purpose of a wire the first entry. How it look like it. diagonal. LED를 주셔야죠. I bend the wire for LED to which wire is which?
Okay, please show us the IVUS finding of LED, then we'll move to the Gangnam.
Okay. 그러시겠죠?
네.
Yeah, 라이브가. You wanna come back or just finish it? IVUS on the
According
screen?
to the IVUS finding, we can discuss the 2 stent or 1 stent. This might be the final visit to you.
Yeah. Really? Okay. This is the distal to diagonal. Where is wire? Wire we can see here. Proximally, I push the IVUS catheter here, proximal to inside lumen. Right. Of course, there are a lot of plaque. Save it now. Okay. Anyway, we dilate diagonal, and hopefully, I like to finish with the DCB. For diagonal, is a good idea?
I prefer 2 stent.
Two stand, electro two stand. If you want, I can do that. So, 1.5 balloon 주세요. 1.5 balloon.
But the diagonal wire is looks like in the center of
일점.
the plaque.
Right.
So you can finish
1.5.
the DCB, I think.
Yeah. So I'm not sure about the plaque shift from the diagonal to LED. And there is a plaque is floating around the bifurcation area. It's kind of difficult to finish with the one stand technique. But the image is image, so you never know. So put dilate each side and put the stand in the LED then rewire, we can see inflation.
Okay. Any comment
And
from the
Roll
panel
it
for
forward.
the strategy
Deflation.
2 stent or 1 stent with DCB?
14.
So I think evaluation for diagonal branch by IVUS
Deflation?
would be essential to decide
Really?
stent strategy.
Okay, Angel?
네.
Sure. Okay. So, actually,
Congratulations
Well,
on your beautiful results.
yeah,
I,
beautiful and my luck. Actually, IVUS is determining the need for two-stent technique here because we'll see a lot of play up to the ostium. So I like rather IVUS. I like to dilate further LED and the diagonal and put the stent. Then we can decide to stent or not. This is provisional approach.
It's a very important diagonal branching, and the wiring is very difficult.
Okay.
So I think the two-stent technique.
Yeah, the stent technique, actually, there is no difference in the end. The two stent versus one stent technique. And
we,
okay.
if we achieve
2.5.
the optimal MSA in both
그 밑에까지
stents,
가야겠다.
the outcome
2.5, 20.
not bad.
스텐트는 여기까지 가야겠는데? 응?
Yeah, I agree that the decision to DCV or stent should be made after larger balloon dilatation of the right diagonal branches. So if the post-balloon result is acceptable, you may consider, but if not, straight stent stenting.
Yeah, thank you very much, Dr. Gu. 마지막 N족, 저거지. Okay. How many minutes do I have? Inflation? 10? Deflation? How much time do I have? 괜찮아? 14? Dr. Zhang?
Yes.
Yeah, how much minutes? How
One-
many minutes do I have?
1
Deflation?
minute.
1 minute, okay. So I try to put the two-stent technique in 1 minute. Inflation,
Okay.
14.
14. Okay, deflation. Diagonal, actually, we like to see the IVUS for diagonal to check the size of the diagonal artery. Actually, we are out of time. So I just like to show, actually, the after balloon IVUS is easier, but for the time constraint, I like to show you the IVUS from the diagonal.
Okay.
In the beginning, you showed 3 options for diagonal branch wiring. In the retrospective, which way do you think we?
In my mind, actually, I tried the proximal one because this is easier, the higher success rate. If we start proximally, then wire end up in the middle of diagonal. So usually, previously I tried the distal one flushing, but I failed a few times. So afterwards I proximally try, then wire is going in the middle at the end. NG? Okay, NG. Very good second operator. Okay. Let's do diagonal. 좀 더 가까이 오고. Okay. Yeah. IVUS. 2.0. Just 2.0. Yeah, it's sustainable. It's getting larger than 3.0. There is some hematoma outside. There's some hematoma here. The first wire is going outside. It is a 3.0, some calcium in the middle. It's getting larger, even larger. That's a hematoma.
Island. 저기 아까 두분 아까 본 거.
Okay, the posterior
Okay.
modeling. Okay, stop.
Very good. So
Maybe
you
you can-
decide to stent?
Yeah, I think the vessel is quite big. I decide to stent technique. But which technique, don't ask me.
Okay.
Because tap technique is my preferred one every time.
Okay.
So diagonal 별로 내야지. diagonal 1.5.
예.
Okay, Dr.
Yeah.
Gwon,
2.5.
congratulate
Yeah.
for your successful procedure.
Yeah.
Thank you very much for your efforts.
Yeah.
Thank
Thank
you.
you very much for joining with us.